Thank you very much. Thank you to the Dravet Syndrome Foundation and Dr. Perry for inviting me to be here today. Let me see if I can get this started. Okay, so let's pretend that we move forward 5 years, and I'm going to show you the results of a natural history study. But it's not. It's a retrospective study. So we looked at adults, and we found different things, and I'm sure some of you here participated in this study, and the comment that was raised just now made me think we will get these results back to you, everyone that participated in this study. But let me start with my disclosures, and then the outline. I'll talk quickly about transition, then the changes that we see in adults with seizures, with regards to seizures, and the other changes that we see. So transition is this planned movement of adolescents with a chronic medical condition from the family center, pediatric system to the adult center, to the patient-centered adult system. What happens if we don't have a proper transition is that most families will feel abandoned by their pediatric neurologist or by their pediatric care team. And usually they had an excellent care in the pediatric ward, and it's, as Dr. Perry mentioned, it's difficult to have such a good care in the adult ward, and we have to train more adult neurologists to do this, and that's why part of our session tomorrow is going to be around that. So back in 2014, we did an interview with neurologists and asked children and adult neurologists, so child and adult neurologists, how comfortable they felt treating patients with genetic conditions and genetic syndromes. And it was very clear there was a huge difference between the level of knowledge and comfort that an adult neurologist had compared to a child neurologist. Child neurologists are much more comfort treating patients with genetic syndromes, intellectual disability, and certain malformations of cortical development. So in terms of Dravet syndrome, we see that in the fact that for every 7 studies that are focused on children, there's only 1 focused on adults. And this is a huge gap, and the adult population and the Dravet population is getting old and moving to the adult system, so we need to know more. In order to help with this transition process, the Medical Advisory Board of the Dravet Syndrome Foundation got together, so we got together, and we wrote this paper, which has this thing. It's a table, which is, the intent was to do a 2-page table that you could print and laminate and carry with you, or if you're a bit more modern than I am, you can go to the Dravet Syndrome Foundation and just download the PDF. So the idea is to have a document that briefly explains to the adult neurologist or to the adult physician in the emergency room that you have to go with your child, that will tell him or her what Dravet syndrome is, what are the main issues, how to treat seizures, how to treat emergencies. So it's a 2-page, again, that has the basics that every adult physician seeing a patient with Dravet should know. Okay, so let's now talk about what really happens to the patients when they become adults. In terms of seizures, we see that the frequency of seizures tends to decrease, and this starts to decrease after the age of 13 years. The types of seizures also change a bit. The myoclonic seizures can disappear, and the atypical absences can also disappear. The sensitivity to fever or high temperature decreases as well, although they can still have fever-induced seizures, it's less common. The convulsive seizures tend to be restricted to the sleep period. So either when they are sleeping at night or they are taking a daytime nap, the seizures tend to happen during this period, and they are usually generalized seizures or focal with secondary generalization. The ICU admissions due to status epilepticus tend to decrease. They are much more rare in adults, although they might have periods of increased seizure frequency, so they are doing well, they are having way less seizures, but from time to time they might have a period of more seizures, and sometimes it's associated with infection, but sometimes we really can't tell why they're having more seizures. And finally, some adult patients can become seizure-free. This is just a result of a study that is not published yet. We are still working on this, but we did, like I mentioned, we invited several parents and caregivers of adult patients to respond a few questionnaires and help us understand, and we could see clearly that the number of status epilepticus decreases in adult patients. In terms of treatment, the treatment is the same as for children, except it might be a little tricky if the diagnosis is made in the adult. So if you have a patient that comes to you at the age of 32 and has been on carbamazepine for 31 years, it might be way trickier to remove this carbamazepine. It might take much longer. And there might be a little increase in seizures before you can actually see a benefit and you have to replace it. It can be a bit more tricky, but as long as the patient has a loss of function, this patient eventually would be better off these contraindicated medications. We made a note about stiripentol. We published this because when we started stiripentol in these patients that were stiripentol naive, so these are adults with a late diagnosis, we started removing the medication and we give them stiripentol. They didn't do as well as we expected. Parents complained of side effects. I'll go back to this slide in a second. But they complained that their adult children were having too many side effects, and some of the parents wanted to stop the medication, even though there was some decrease in seizure frequency. And we decided to look at metabolic if there was something different. And I can't explain exactly why we thought of ammonia. It was more like a hunch. And we decided to measure the ammonia in these patients, and it was exceedingly high. And so we treated this with carnitine. It brought the ammonia level down, it improved the side effects, and many of those patients could continue on carnitine, on stiripentol, reap the benefits of seizure reduction on stiripentol with controlled levels of ammonia. This slide here was just to show the hesitancy in starting stiripentol. So the X, the red X, is when the diagnosis was made, so after the age of 18 years. And some of the patients, it took more than 5 years to start stiripentol. And many of the times it was because parents said, you know what, he's having way less seizures than when he was young. And I don't want to do anything at this point. I don't want to rock the boat. But still, it was like 10 seizures a month. We have adults having 2, 3 seizures a month or seizure-free. So after a while, those parents really thought, okay, maybe there's something else we can do. And we end up getting them a better treatment. This is something that is not yet published. It's part of this study that we asked many of you to participate, and it is related to adaptive skills, which was talked before. So we did Vinelands, or many of you answered all the questions in the Vinelands, and we saw that older patients do have a significant decline in several of these adaptive skills. Actually, they have a declining, all of them, most of them. And this happens with age. Socialization skills also worsen with age. I have here both expressive and domestic and written and communication, receptive and personal domains, all of them decline with age. This now is about gait and Parkinsonian manifestations. This is a paper we published just recently, and for us in the academic world, if you get an editorial, it means someone paid a bit more attention about your paper and thought it was necessary to talk a bit more about that. And the reason why it did that is it was the first instrumental gait analysis that was done in adults. And what that means is that there was a special mat where these patients walked, and there were several cameras on them. And we could analyze several different things that tells us about the way the gait is. So the patients had to go back and forth 2 times. The cameras were there. Oops, let me go back. And this is, why it's not playing? Okay, so this is a patient of 50 years old, and you can see she has what we call a Parkinsonian gait. She walks with very small steps. She walks very slowly. She doesn't move her arms when she's walking. She has a stooped posture. Her neck is bent forward. Sorry about that. Okay. And it's a gait that we see in several patients with Dravet syndrome. This is a different patient. She's 42 years old. She's more ataxic, meaning she has more balance problems. She has a wider base. She's generally weaker. And overall, we had several of abnormalities with these patients. Here, there are several different things that were analyzed in these patients. And basically, what it tells us is that they have more difficulty walking. They need to be more time with both feet on the ground. This thing that we normally do, that we walk, we do one step and the other feet is coming out of the floor, and then for a period of time we don't have that put on the floor, and then we put it again. They don't do this they have significant difficulty to do that, so they really have to keep both feet on the ground for the majority of their walk. Now, this study showed also that the older patients had more gait difficulties. And because we did this during the pandemic, we really could not recruit controls to come to the lab and do the same thing. So usually when we do a study like this, we want to get age-matched and sex-matched controls. Because we could not get, we got a historical control. But see, our patients, their median age was 31 years old. The historical control that we had was 62 years old. And unfortunately, our Dravet patients were worse in all domains, worse compared to the 62 years old. So really a sad finding. In terms of the Parkinsonian features, back in 2014, we noticed that our patients had Parkinsonian features, which include the gait, but also the fact that they move very slowly, they have this rigidity, they have difficulty with the muscle, the level of tension in their muscle. They have the hoarding behavior, which is also part of the Parkinson's. And we followed those patients and repeated all the exam again 5 years later. So we couldn't really recruit all the patients that we saw in 2014, but we did the same test in 5 of those patients. And out of those 5, 2 of them that were walking before were no longer able to walk, unfortunately. All of them got worse over those 5 years. The Parkinsonian symptoms in general got worse for all of them. The only one that really didn't get worse was the first one, which was a patient that was put on levodopa. We also put the other 2 that stopped walking. They were also on levodopa, but maybe it was too late, or maybe it didn't work with their particular abnormality. But the one that was put on levodopa earlier, she actually improved on the second time we examined her. So here, just to show that everything, the different things that we see, getting out of a chair, the speed of movement, everything got worse with age. This is now, oh my goodness, it didn't disappear completely. Okay. Sorry about that. I'm going to have to restart. Oh. No, this one. Again, this is part of the study that we have not finished. We are still collecting data. I don't know why it's not showing there. Okay, let me try. Just be patient with me. I know it's all that is standing between dinner is this slide that is not working, so sorry about that. One thing that was talked today, again, was about autism. So we didn't try to do a diagnosis of autism. To do that diagnosis, it's a battery of tests that takes several hours. You have to have the trained person directly with the patient. We really couldn't do this, especially in the setting of the pandemic. So what we did was a screening test for autism. It's a questionnaire that you answer, and if you have this amount of positive findings, it's a red sign saying there's a high chance that this person has autism, you need a formal assessment. And what we saw is that in the adults with Dravet syndrome, 77% of them were positive for this screening. As it was said before, in children, the numbers vary between 32 up to 60-something. But that is the real diagnosis. So we don't think that the 77% would necessarily have autism if tested with the formal long testing called ADOS. But what it tells us is that probably there's way more adults with autism that are not being diagnosed. Okay, so to finish, adults with Dravet have less seizures, less status epilepticus. Although they are still sensitive to seizures, they can go through sensitive to fever, they can go through infections, sometimes episodes of fever without going to status epilepticus. As they get older, their gait deteriorates, many become wheelchair bound. Parkinsonian symptoms also get worse with age. Levodopa may help a few patients. The role of contraindicated, I didn't talk about this, but we are looking at the role of contraindicated medications on gait and Parkinsonian manifestations as well, and autism might be higher than what is really diagnosed. So I'll stop here and thank all these people that work with me and our collaborators.
Okay, questions?
Hi, you know, these are obviously very neurological effects of Dravet that go on when they get older, but what about the other adult things that happen to people, the high cholesterol and high blood pressure, diabetes?
Yes.
And especially with the lack of movement, the osteoporosis, what happens to adult children or adults with Dravet in those areas?
So they have all the other complications that adults have. They do have high blood pressure, they have diabetes type 2, obesity in some cases. So I have patients that when I started seeing them at the age of 18, they were very skinny, but with time they become less active. And part of, remember, it was said earlier today, they have ADHD, but as they get older, they get more passive. They don't move so much, and they have gait difficulties, so it's another reason to put on weight, and then that will make their joints worse. So yes, they have all the other complications that we see in adults that are inactive, Yeah, so on top of their neurological problems, they have all the other complications.
Do you have any idea if physical therapy helps in prevent or treat any of the Parkinsonian traits that you see in the early 20s?
The Parkinsonian specifically, I would say probably not. I don't think in the movement disorder world, physiotherapy in general, it's the traditional physiotherapy at least, no. There is some suggestion that dancing or having more elaborated activities could help, because it's just like when you're dancing, you have to do the connection between your brain cells and your muscle cells, so, and think of the movements a bit more. So there is some suggestions that in patients with Parkinson's disease, some activities can help. The other thing is, we don't have really studies saying if this patient that did physiotherapy end up much better than this one that didn't. So that's the study that hopefully we'll see in 4 years from now.
I happen to have a child who's an adult, 24, so thank you so much for this presentation. I do think gait issues is a real issue for many of us who have adults, especially hearing this, and I'm curious, and you talked about, you know, the sense that obviously gait issues or walking becomes more difficult as they age. So do you have any perspective on what kinds of studies are being done to really address what's causing the gait issues and what can be done, you know, more in the long term to kind of prevent these challenges that all of us who have adult children are going to soon face?
I don't know much about the studies being done in the pediatric ward. I guess, Andres, maybe you know of some. I mean, the prospective studies, the natural history studies will obviously address this issue. And the one thing that we have as a big confounder, we don't know how many of these patients have parents that push them to walk, or how many have parents that say, you know what, I'm afraid you're going to fall and break a bone, because they also have osteoporosis. So there's so many confounders. I really can't answer your question. Sorry about that.
Thank you for that excellent talk. It actually reminded me of an adult Dravet syndrome patient I saw in the epilepsy monitoring unit when you talked about the hyperammonemia, the side effects. What do you do if you have a medication that's effective but it's causing all these side effects, such as difficult in adults? We've found that she really did well with it, but was not tolerating the side effects, even when put on levocarnitine. Is there any other strategies or workaround to be able to deal with these side effects or these metabolic, especially the metabolic ones? Oh, not you, Siri.
Let's see what Siri found on the web about that.
Maybe she has a better answer. With regards to the ammonia, we use lactulose because that helps, because these patients also have constipation. But with regards to the other issues, I mean, you have to manage individual, whatever it is that you're finding. But the lactulose actually can help also with the constipation.
I just wanted to share your question about how to overcome some of the things as time goes on. My wife and I have a 41-year-old male who we've gone through all the cycles with. And one of the things that we do, he's in a group home now, but we encourage them to walk on the trail, and they do that with the other consumers in the group home, and we always do that too. He has the gait issues, but he's still, when you walk on steps, you just say, watch your step. He does continue to walk. So the one encouragement I'd have, having had the experience, is keep them active. Just keep walking like they tell all of us to do. You know? So that's fine.
Thank you for a great talk. I was just wondering, I'm one of the adult neurologists. Are most Dravet patients that come into adulthood, are they diet naive? Like, have most of them tried the ketogenic diet, or have they not? And then kind of a follow-up on that, are there certain characteristics maybe in adulthood that may or may not lend well to the ketogenic diet?
I would say that probably 80% of our adults have tried the ketogenic diet. And if they didn't, we tried the modified Atkins diet. If they have any inherent trait that make them respond or not, I don't know. I don't know. I never read anything about, other than certain genetic diseases that you know, like if you have a GLUT1 deficiency. But if we're talking about SCN1A, why some patients would respond and others not, I don't know.
Any more questions? No? Then if not, thank you so much.